PT on Ice Daily Show. And today is Clinical Tuesday. My name is Eric Chaconis. I'm one of the faculty in our extremity management course, along with Lindsey Huey and Mark Gallant. And extremity management's a live course we offer. It's 2 days, all things exercise progressions, manual techniques for the shoulder, elbow, wrist, and hand, and then hip, knee, foot, ankle. We have a lot of courses coming your way in 2022, so we're kind of all over the country, really. If you've ever wanted to take extremity management, it just hasn't come to an area near you. I think you won't have that problem in 2022. The first one's in the middle of January. Will be in Atlanta, in the southeast. So at Onward Atlanta, Monique Cofino's clinic, just on the north side of Atlanta, in Roswell, Georgia. It's a great facility, great people. Really going to be a fun weekend. So that's middle of January with Lindsey Huey. And then after that, you'll see kind of all over. There's a lot of different options for you. Another announcement I have, speaking of Lindsey Huey, Lindsey just graduated with her Doctor of Science degree from Bellin College. So really congratulations to Lindsey. So awesome, and just couldn't be more excited for her. So you'll see some of her publications coming out soon now from all the work she's been doing lately in that program. She was on a team that looked at therapeutic alliance, and they looked at all the different variables between the clinician and the patient and kind of what makes good therapeutic alliance for individuals seeking care for musculoskeletal pain. She also completed a systematic review with Kevin McPherson from the University of Florida, looking at resistance exercise reporting studies for chronic low back pain. So talk about impressive. I just couldn't be more excited to have gotten to know Lindsey over the last few years. She works with us here at ICE. She teaches at South College. She's been working on this degree for some time. She's a mom. She's got 3 kids, super busy, got a great husband, small private practice. She's a busy person. So congratulations, Lindsey. I'm so happy for you, and really couldn't be more excited to have gotten to know you, and really grateful that our paths crossed when you started this degree. So today I'd like to jump into a paper that we posted in Hump Day Hustlin' this past week. So if you're not familiar, Hump Day Hustling is an email blast. We send it out every Wednesday. We basically curate what we think are kind of the most current and relevant research papers that would be interesting to your rehab professionals. And we blast out every Wednesday. So if you're not on that list yet, if you go to our website, ptonice.com, you scroll down to the bottom of the page, you can just enter your name and email there, and you can get on the list. So we've really gotten a lot of good feedback on it. It's a great resource for people, and we have fun kind of curating and finding all the studies and talking about them amongst ourselves as they get blasted out. And so the one I want to talk about today and kind of highlight and focus on, Jeff actually found this one, and it's called the FIMPACT study, and I linked it in the description on Facebook and on and if you are on Instagram, if you just Google FIMPACT study, you'll see it was just published in BMC Musculoskeletal Disorders in October. And so this is a study out of Finland, and they randomized 184 people with subacromial impingement. These are people with like chronic subacromial pain. They've had pain for greater than 3 months and sort of failed a first line of conservative treatment. They don't really describe what that is and what they got. I don't know if that's just like a first course of NSAIDs or wait and see or what it was. But anyway, they randomize them into 3 groups. All right. So one group gets your typical subacromial decompression surgery, where they debride the undersurface of the acromion. All right. They sort of try and clean out that subacromial space. Another group, they just get the diagnostic scope. So they go in, they go in just like they would if they were going to scope your shoulder, but they don't actually do anything. It's just diagnostic. So they look around, with the camera, looking at the space. If they saw a rotator cuff tear or something like that, they repaired it, and that person left the study. They didn't keep them in the study. So this is like trying to create a true sort of placebo arm, right? A sham control arm that doesn't actually get surgery, but the person thinks they get surgery. So the patient is blinded. They think they got surgery. They're knocked out. When they wake up, they've got the sutures in their shoulder, and they're in the operating room, and everybody, it seems like they just got surgery. They're totally blind to what happened. The researchers are also blind. So the people in the operating suite, they are not the researchers. They're the only ones that know, but they're not involved in the study like that. The researchers, all the outcome assessors and all the people that are going to be following up, they're completely blind to whether that person actually got the decompression surgery or they just got that sham diagnostic, sort of stick a camera in your shoulder, look around, pretend like you got surgery, and then pull it out. And then they have a third group that gets exercise rehab, basically physiotherapy, right? They see a physiotherapist. They describe it as a standard program, 15 visits over the course of 15 weeks. So they go in, see the PT once a week for 15 weeks, typical run-of-the-mill exercises. Now, this is a big limitation to this study, and it's hard to find exactly what was done in that group, and I don't love that, right? Even as I look down this chain and these researchers and the stuff they've published before, when you read the paper, you really have a hard time finding, even in the study protocol, what exactly was done in that group. I'd love to know the specific exercises and the specific techniques that were used, right? That would be helpful. But anyway, that's a negative. It's okay. This study really is the next step, though, in the progression of what we've learned about shoulder impingement. And so, you think back years and years ago, this diagnosis of shoulder impingement described by Neer in like the 50s, or, it was a long time ago, right? That it was initially described, 50s or 60s, of the head of the humerus riding up and approximating into the undersurface of the acromion. The idea that you're crowding that space, and that's the problem, right? The problem is there is, for whatever reason, a lack of space between the acromion and the head of the humerus. If we shave off the underside of the acromion, that'll help. That'll open up space, right? And it's the most common procedure. It's been, over the years, one of the most common procedures done in the world. So all based on this premise that was developed years ago. Not strong science behind it, by the way. Like, we've had a lot of studies that have been done over the years and have shown this procedure doesn't really make a difference. When they get subacromial decompression, it doesn't actually change the outcome if you compare it to exercise and rehab. If you compare it to sham or placebo, this has been done before. The difference is they usually aren't looking at return to work as a primary outcome. They're just looking at pain and function. So some people would make the argument that pain and function is more susceptible to like surgery as a placebo, and maybe like if we look at return to work, people that actually got the procedure, they'll definitely get back quicker, right? The other thing that hasn't been done very well before is this blinding effect, right? So people usually knew whether they got the surgery or not, and the surgical team was usually involved in the study. So you didn't have this kind of double-blind scenario where people have no idea whether they got the surgery or not. So that's what makes this study fairly novel and pretty cool. I think that when you look at the prior research and you look at the Cochrane reviews and you look at the 14 randomized controlled trials that have been published and all the research over and over and over again, it all says the same thing. It all says the same thing, that really when you look at outcomes, there's no difference whether you get the surgery or not. And so this is not new information. This is confirming what all these prior studies have already found. And I think the next step now is really, what do we do with this information? It's crazy that this has been published time and time again. You have a large guideline-based meta-analyses and systematic reviews that all say the same thing. There's really no difference. What's the value add for subacromial decompression? I think that's crazy. I think, first of all, you have to understand the limitations. We're looking at means. So it's the average, right? The average of all these people, there's no difference between groups. Doesn't mean that there aren't some people that respond better than others. It doesn't mean that some people don't respond at all. So there are people that do not respond to exercise and rehab, but do respond to the surgical procedure, and vice versa. So there's still individualized factors that need to be considered, and obviously it's all going to be case by case. But overall, when you look at broadly, when you look at the literature and you look overall at the average, there isn't really a difference. And that's probably what needs to guide policy. That's what needs to guide clinical practice guidelines. And that's what we need to do is really educate everyone on that fact. There's a lot of things our patients are asking us about. Hey, should I go and get this procedure? Or hey, I'm not feeling as good after 4 weeks of rehab. should I go and get my shoulder scoped? And you want to use the evidence really to direct that conversation on top of the individual factors. I think the thing that kind of rubs me the wrong, or not, it just sort of still sits uneasy with me, is I'm like, why is this still such a commonly performed intervention for shoulder pain? Why haven't we learned? And you could say the same thing, by the way, about clean out scopes for degenerative meniscus tears in older individuals. You could say the same thing about rotator cuff repairs. I did this exact same topic, this episode, on specifically rotator cuff tears, which, by the way, you can make the same argument back in April of last year. If you're interested, let me know. I'll post a link to that. But that same thing, podcast episode just like this, highlighting the research where we look at rotator cuff tears and surgical procedures, and when you compare those to rehab and what the difference is. But in the United States, we do about 500,000 of these every year at about $25,000 a piece. So that's a lot of resources going into this, right? I mean, think of the surgical team, anesthesia, recovery time, diagnostic imaging. I mean, the list goes on and on. And to think you can get the exact same outcome by seeing a physical therapist once a week for 15 weeks, probably less. That's crazy. I'm pretty confident we can improve that rehab outcome. I'm pretty confident we can shave that down from 15 visits to get a little bit less. I need to see that program and what was done, right? Really appraise it. But what's that cost? Even if you go the full 15 visits, what's that cost? $2,000? I mean, what are we doing? The healthcare, like $25,000 versus $2,000. Why isn't everybody mandated to go see a PT first before you get the underside of your acromion shaved off? Just makes more sense, right? And what does that PT look like? I mean, I think that's really the key. But healthcare, when you look at the healthcare sector and the financial side of it, it's really not sustainable. I mean, we're wasting way too much money, right? We're not following evidence. We're labeling people with these scary diagnostic terms that probably aren't even true. And we're starting to realize the head of the humerus might not really be approximating against the undersurface of the acromion. That pinching description we're using, that impingement term, is probably not accurate. Jeremy Lewis was publishing that 10 years ago. It's subacromial impingement. The word impingement is probably not appropriate. They have pain in that area, okay, so call it subacromial pain. Don't call it impingement. That creates a nocebo, a thought virus in the person's mind. Can you imagine if you didn't know anything about this and you're picturing you're picturing pinching and impingement in your shoulder? Of course you're going to want to get it cut out. Of course you're going to want to get that space opened up because you think in your mind, oh, it's impinging, right? It's compressing. I got to get that cut out. So I firmly believe nobody else is going to step in and correct this. The insurance companies don't care. I don't think they care. I don't know. I'm not an insurance expert. I actually think they kind of like it when costs are driven up because premiums get driven up. So it's all percentage based. They probably like it. I think they like a degree of waste and all this, right? They're probably not fighting this excessively. It doesn't seem like it. I don't really know anything about that. I could be wrong, but I think it probably allows for higher premiums. I don't think they're incentivized for whatever reason to create a leaner, more efficient system until we see some new, a new model of care come out. I don't think anybody's really incentivized to do that. I definitely don't think the mainstream medical community is very motivated to improve this, right? They don't see this as a major problem. And a lot of people probably look at this evidence and just kind of shrug and say, well, but there's exceptions. My patient, I don't know. I don't know how do you answer this? How do you argue against this? I really have a hard time understanding that. But bottom line is it's up to us. It's up to us to educate everyone and let them know, bring this evidence to the forefront and talk about it and share this evidence and talk about the success that we've had. I mean, even if you've had success anecdotally, you can describe that to people and show, look, I've had a number of people in the same situation. They've done really well with a course of rehab. It's safe, it's effective, it's a low-cost intervention, requires some work, requires some effort, but you're going to have to put in work anyway in post-operative rehab. Might as well just do it without the surgery. Save the $25,000, save the headache, save the time that you're knocked out and all that sort of stuff. So, we have to do that. We are experts in conservative management of musculoskeletal pain. It's up to us to improve the system, advocate, and then hopefully on an individual level, help people make good decisions. I mean, give good recommendations. That's really the bottom line. So, hope that helps, and I will talk to you all soon. Have a great day. Have a wonderful, happy New Year. Take care, everybody.
Hey, thanks for tuning in to the PT on Ice Daily Show. If you enjoyed this content, head on over to iTunes and leave us a review. And be sure to check us out on Facebook and Instagram at the Institute of Clinical Excellence. If you're interested in getting plugged into more ICE content on a weekly basis while earning CEUs from home, check out our virtual ICE online mentorship program at ptonice.com. While you're there, sign up for our Hump Day Hustling newsletter for a free email every Wednesday morning with our top 5 research articles and social media posts that we think are worth reading. Head over to ptonice.com and scroll to the bottom of the page to sign up.